Well, hey there, and good evening to everyone. It is 5 o'clock. 5 o'clock on the Gulf Coast, which means 6 o'clock on the East, 4 o'clock in the mountains, and three in the West. And there is only one place that you need to be right now, and that is right here. And that is Fertility with Fink. My name is Dr. Randy Fink, and I am a fertility gynecologist at New Life Fertility in Pensacola, Florida, and with offices also Panama City and Mobile, Alabama. I also do some work with the Missouri Center for Reproductive Medicine, MCRM, and that is where I am tonight, live from Tulsa, Oklahoma. I am at the Tulsa office this today and tomorrow, doing some embryo transfers, hoping people will get pregnant, doing some exciting work here. So we are part of the renowned First Fertility Network, your nationwide network of fertility experts. Great to see everybody here. Happy Tuesday. I hope your weekend was great. We've got tornadoes and all kinds of storms happening in the middle of the country here. And let's see who we have. Hello to JK or Jake, if that's what that says. Noodles for Life. Hello. Hi, Rosa. And Clark and Carlistine Krause. It looks like that says. Marlena, you were number one to join in the program tonight. Thank you so much for being here. And that is Randy Fink, MD. That's my Instagram over here. We've got another Instagram here, and that's New Life Fertility. Hello to Marin, Marin the Wonderful, Marin the Fabulous, Marin the Fantastic. Good to see you this evening from New Life. We've got Facebook, we've got YouTube, we've got LinkedIn, we've got all kinds of different social media here. So thank you very much for making our program a part of your week. Every Tuesday evening, we do the same thing here. Come together to talk about all those things that have to do with getting pregnant, staying pregnant, making families, and all things that are women's health. So if you have questions, please feel free, ask away, and I am happy to answer for you here. One question that I had a little earlier was, well, all right, so there you are in Tulsa, Oklahoma. Do they do things differently there than they do at your home office, main office in Pensacola? And the answer is, there's some little nuances that are different. And one of the things that I particularly like is sort of when I'm doing consultations for patients at MCRM, that I'm able to really, see how people approach problems differently. And sometimes it's really beneficial for me to be able to look at a problem sort of from the outside, to see it with a different set of eyes, or at least a different perspective from the way they normally do. And that really just, it kind of keeps things interesting. It helps patients to get to their ultimate goals of having a family. Really that's what we do here, and that's what we love. A special hello to the Bama gal. That is my beautiful mother, who probably sitting alongside her is my beautiful father in Mobile, Alabama. Thank you for being here as every Tuesday. Hi to Tracy in South Florida. Let's see. Car Carly Steinkraus says, hello, Dino. And she says, oh, wait a minute. That I didn't mean to say Dino. I guess that was an autocorrect. No one's ever called me Dino before, but I kind of like it. Dino, or you can say Dino. I guess that works. That works too. Rosa asks, well, let's see. Going back to Carly, I'm fighting my lining to grow for my transfer upcoming follow suppression with Orlissa 200 milligrams twice daily and letrozole 10 milligrams at bedtime. Any tips? I started February the 16th. The lining is 5.5. I did PRP last Wednesday, and I'm on Viagra now. 4 times a day. My guess is that it is going to do what it's supposed to do. I'm pretty confident that it will. And it sometimes just takes a little time. So, what she's asking about is that she was on suppression for endometriosis, right? And so we know that when endometriosis is present, or particularly the BCL6 marker in the uterine lining, it means that it creates an environment that opposes your own progesterone. And that's the most important hormone of the pregnancy, right? So, if you've got something that's working against your progesterone, then well, that's a problem. So, what do we do with that? We turn down the volume knob on that hormone, on that marker. We turn down the hormone volume knob for 60 days in order to basically shut it down, and that results in returning really all the way back to kind of normal activity of the endometrium. But when you have been on such suppression, and you were on a pretty high dose of letrozole there, along with the Orilissa, it tends to really turn things off. It can just take a little bit of time for it to start to come back, but it almost certainly will. One other thought is that there is a form of injectable estrogen that's called del estrogen, and usually you take a shot every other day. And a lot of times when transdermal estrogen, a patch or a pill through the skin, when it's not doing it, sometimes the estrogen will definitely do it. Now, if you find, and the PRP is also really a great answer there. If you find that the PRP and these other methods are not cutting it, there's no harm to saying, you know what, I'm going to take a little bit of a break. Let me just give it a little bit of time off the suppression, because then my own hormones are going to kind of restore themselves back to normal, and things should function normally. But del estrogen is something that I will use for people with really resistant linings, where that lining doesn't want to grow, doesn't want to grow back. It's also very inexpensive, and so that's kind of a nice thing about it there. We love our new life nurses, says Marlena. That is awesome. Thank you for saying so. Shadia, good evening to you. It's nice to see you. Hi, Create Davis. Noodles for Life says 2 weeks post Provera and still no period. Does no Mincy's start medicated? Does no Mincy start medicated FET can still be successful post a canceled previous FET due to the lining stuck at 6 millimeters? So, will the lining reset itself? I was on Orilissa, and the body didn't seem to respond so much after. Well, that's interesting. So here we have a couple of people who have been suppressed and then have had a hard time getting their hormone levels to turn themselves back on to do what they're supposed to do. This is actually a pretty good case for del estrogen. Now, people talk about, so there's a couple of different ways, to do an FET cycle. One is a natural or a modified natural cycle, where you're going to make your own estrogen, and your own estrogen will then build that lining. You can do that by taking some letrozole for ovulation induction. You can do that by just letting your body do its own natural thing. So the first thing I'd have to wonder is, okay, you got some Provera. What's Provera do? Provera is designed to give your body the fake signal that you had ovulated and didn't get pregnant. So you've basically, what happens when you release an egg, when you ovulate, the little space that's left behind, which is called a corpus luteum, that corpus luteum makes for you your progesterone. Um, your progesterone level rides along like this until it sees that you're not pregnant, and then it goes like this. And it's that dropping progesterone level that triggers you to have a nice normal period. So when you take Provera or prometrium, micronized progesterone, or agestin, norethindrone, or even a birth control pill, you're getting that hormone, you're getting that progestin hormone, and then that hormone level is dropping off, which is what we call a withdrawal. And that withdrawal is what stimulates you to bleed, to have your period. Um, the fact that you got some Provera and didn't bleed their noodles makes me wonder, did you have sufficient lining there, really to slough off anyway? Sometimes I think that the best thing that you can do in this situation where you're doing this incredible clawing your way uphill after suppression to try to get a lining back is to say, well, you know what, that suppression probably really lasts you for 6 months or so. I think some of that may have to depend on like body mass index, but 3 to 6 months. So certainly if you stopped with your suppression, um, um, and you're not growing the lining back and you're on medications and it's still not working, I have a little problem saying, you know what, again, let's just take a little break. Let's just see what's going to happen in a natural cycle. Or can we get you to ovulate? Can I give you some letrozole, which is going to make your own estrogen, which is probably going to make your own lining? No problem. And just taking a couple of weeks off and letting your body live without the suppression and without the extra hormones. And that may just cause things to reset. I have never seen a situation, and I want you to hear this. I have never seen a situation where someone was on suppressive medication and then stopped the suppression, but ended up not able to grow a lining or not getting a period. In other words, your worry, I think, is that you're on suppression and you stop the suppression, but you stay suppressed. Not going to happen. I feel very confident about that. You'll grow your lining back. You're just having to jump through some hoops. So sometimes a little bit of a pause, even a couple of weeks, may be enough to get you rebooted there. Hi, Claudine for Navy. I like it. Sarah, good evening to you. The Styles family. Hi, how are you guys tonight? Nice to see you. A. Clark says, I'll be graduating in a few weeks and I'm so nervous to stop the progesterone injections. I have a subchorionic hemorrhage that bleeds on and off. Is there any benefit for me to advocate for extra time? And the answer is no. So first of all, let's talk about that subchorionic hemorrhage, because if you saw my post earlier in the week or last week or whenever it was, folks with a subchorionic hemorrhage, I emphatically recommend that you take alpha lipoic acid, or ALA, alpha lipoic acid, 600 milligrams a day, along with your progesterone. There's some very good evidence that alpha lipoic acid, along with progesterone, decreases the risks associated with that subchorionic hemorrhage. It results in that sort of bruise under the placenta being able to heal itself more rapidly, and ultimately less bleeding and less risk for that bruise expanding and separating the placenta from the rest of the uterus, which, as you know, we don't want that to happen. So alpha lipoic acid is the first thing, A. Clark. Second thing is no, because by 9 weeks pregnant, your placenta has taken over the job of manufacturing progesterone. It just does. So that's why we stop the progesterone in oil, the progesterone from the outside, because you just don't need it anymore. Your body makes it. There really isn't a pregnancy that would continue on its own if you weren't making that progesterone. So I think the fact that you do have an ongoing pregnancy, it's not coming from the outside progesterone, that will be very reassuring. And I think it's fine to stop. There is no advantage, repeat, there is no advantage to continuing progesterone after that mark. Now, usually we stop it. I like to stop it at about 10 weeks, because then there's a little bit of overlap from what your body is naturally making from the progesterone and oil to what your body is making there. But no advantage to staying on it. And nor do I suggest that you try to test progesterone levels after that point, because there are no norms established for what that number really should be. I just haven't heard of a situation where a placenta doesn't manufacture progesterone, because that's just what a placenta does. If it wasn't, it wouldn't be a placenta. It wouldn't really have made it to that point. But I understand why you're nervous, because it took a long time, right? It was hard to get to this spot. And so you're worried about, well, what happens if things don't work the way they're supposed to? And I would say, you know what? At some point, we have to trust that nature knows what it's doing, and that our bodies were built to be pregnant. And by when I say our bodies, I don't necessarily mean mine, even though I kind of look like I'm pregnant. That's why I'm sitting down. You don't want to see me standing up. It ain't pretty. Um, but the body knows what to do, and I feel very confident that you will be making your progesterone there. And I think it's okay to stop. I really do. If it would make you more comfortable, I always say, look, if you want to continue some vaginal progesterone for a couple of weeks, then you could do that, just so that you have a little bit more overlap. But the progesterone and oil is hard enough on your poor butt anyway to have to get that shot. Um, I don't recommend you stay on the PIO, but vaginal progesterone if you want to for a couple of weeks, but you really don't need it any longer than that. Here's a question. Is there a critical window to transfer following suppression? I'm concerned to lose the benefits. My estrogen is sitting at 1703 to 2300, roughly, with 2 times a day vaginal and oral. All right. Well, so here's the first thing to know. Vaginal estrogen typically creates very high levels of estrogen in the blood. So, unlike progesterone in the vagina, when you use progesterone in the vagina, it really has a local effect on the lining of the uterus. It's really affecting pretty much just the uterine lining, and what you get in your blood is only a reflection of either the progesterone and oil or what your body is making. Vaginal progesterone does not correlate with serum levels in the blood. Estrogen, however, when used vaginally, makes the estrogen go really high. So what we're looking for with an estrogen is really to try to get your lining to be at least 7 millimeters or 6.5 millimeters. But an optimum estrogen level for embryo transfer is between 2 and 600. So I try to avoid the vaginal estrogen when I can, just because it does create such higher levels there. Is there a critical window to transfer after suppression? Well, that suppression, we know that when you can, we want you to go right from the suppression into an embryo transfer cycle, because that's typically when your outcomes are going to be the best. But you should be able to maintain that outcome for 3 to 6 months. In someone who is not in the obese class of body mass index, I would expect 6 months of suppression. In the first 6 months after stopping, that you ought to be pretty much the same as you are in that first month. And hopefully that answers the question. Hi, Indepino Journey. Good to see you. M Wonderland. OMG Kylie. Hi, Kylie. Perry Myslova. I think that's what that says. Rachel Castelli. Hello. In Wonderland. And who do we have over here? We have Shelby and we have Deanna. Nice to see you here this evening. And over on the Facebook side, here's Jessica, who says, how many months do you recommend suppression prior to an embryo transfer? And the answer to that is 60 days. So if we know that we have endometriosis, 60 days of suppression should be very adequate to turn off the BCL6 marker or the endometriosis effect on the lining. 60 days, Jess, is all you need there. M. Wonderland says, I started a Clomid cycle, 100 milligrams for 5 days. The mid-cycle check at cycle day 12, the ovaries were quiet. I checked in again at cycle day 15, still quiet. The lining went down to 5. Why would that happen? Well, that is an effect of Clomid. So Clomid is what is known as a selective estrogen receptor modulator. And that means that some parts of your body think that it's a pro-estrogen. Some parts of your body think, yep, that is estrogen, do what estrogen does. While other parts of your body think it's an anti or a negative estrogen. And it can have a negative effect on the growth in the uterine lining. And that's one of the reasons that, many of us really don't use Clomid so much anymore, because it can, letrozole often does better, and it doesn't have any effect on the uterine lining. But that's exactly what happened. It's functioned as an anti-estrogen at the level of your uterine lining, and it made it kind of get thin. Now, some people just don't really respond very well to it. And you said that your AMH is 0.1, which means that with that lower AMH, it may be a little bit more of a challenge to try to get your ovaries to respond. But not something that means anything is wrong with you. That's 100% just because of the medicine. Hey, I want to take a moment to welcome a very special guest to the program here. As you know, tonight I am live from Tulsa, Oklahoma, at the MCRM, Missouri Center for Reproductive Medicine facility here. And joining me in our office this evening is Ms. Macy Alsup. So, Macy, you're going to have to come in real close here. And it's going to be, it'll be closer than you feel comfortable. How about that? And that's the only way it really kind of works. So Macy is one of the coordinators at MCRM for IVF. She is a registered nurse, and before working here, she has a history of also being a labor and delivery nurse. So she can also tell you about that labor and delivery experience if you have questions about that. She is good for it, and she's been doing transfers with me here all day long. Macy, we are very happy to have you here. Welcome.
Happy to be here.
So tell us a little bit about, and we will get to your questions here, so don't think we forgot about you, but tell us a little bit about, what brought you to where you are today. Where are you from, and where did you work? And you also worked in the NICU.
I did.
So really interesting stuff.
Yeah, I'm originally from Central Illinois, a town called Decatur. If any of you are familiar with that, I would be shocked. But it's about 45 minutes east of Springfield, Illinois. That's probably one you guys are a little bit more familiar with. But I went to school at Ball State in Indiana. Chirp, chirp, go Cardinals. And I graduated with my BSN, directly hopped right on into the world of labor and delivery. I was actually pretty much everything except for an actual labor nurse. I triaged, I was the baby nurse, I was postpartum, I circulated the OR, the whole 9 yards. And then my husband is also a nurse. So we decided to move on down to St. Louis, where I ventured into a level 4 NICU. And I worked there for a little over 2 years before the night shift got to me. And it was time to move on to the clinic setting, which led me right into MCRM and being a fertility nurse.
So did you always know that you wanted to go into kind of women's health stuff?
Yeah, that's a funny question. So I originally wanted to go into pediatrics, and I was signed to do so, but I was one of those lucky ones that graduated right smack dab in the middle of COVID.
COVID.
That was a really interesting time to not only be in nursing school, but also be a nurse in general. And so whenever I graduated, I had signed on for this peds position actually in Springfield, Illinois. And as soon as I graduated, they sent me a letter resigning that position because they were not hiring anyone due to COVID. So I had to kind of scramble to find a job. And then I landed in the beautiful world of labor and delivery. And that's women's health is where my heart landed. And so then I like I said, fell in love with the NICU. And then fertility specifically actually is also another interesting story. When I worked in the NICU, I had a family who they were both in their 40s. They had tried for many years to have their baby. They had their one beautiful, lucky embryo that made it all the way to 40 weeks. And unfortunately passed from a placental abruption.
Oh gosh.
And I did that bereavement, and that really hit home with me. And so that's actually why I wanted to go into fertility.
Well, I think that that is very noble of you. We got a couple of comments there. Looks like Michaela says, "Go Macy," and Emma said, "My
Emma,
girl."
we miss you.
Thank you guys for being here. Was there anything about um, um, was there anything that so when you worked in the NICU, and I would think that being in the NICU, I know when I was a resident, we had to spend some time in the NICU, and it was always very frightening to me because
Mm-hmm.
I was used to taking care of babies, but I was taking care of babies
Inside.
inside, yeah,
Mm-hmm.
not so much on the outside. So
Mm-hmm.
I found it to be very frightening, and I remember one of the NICU fellows said, they're just little adults. And
Yeah.
I'm like, oh, okay, well, I suppose. And I'm not sure I still kind of believe that. But if was there anything about working in the NICU that frightened you?
The NICU is its own beast, especially being in a level 4. So we were the only NICU in the region really that does ECMO. I think all the way till Kansas City, pretty much. And so
So ECMO, for those
yeah.
who don't know, tell them what ECMO is.
So ECMO is basically your heart outside of your body. So whenever babies, especially those with like pulmonary issues as well, when they're not good at oxygenating their own blood, it's kind of a functioning lung and heart machine that operates outside of the body. So they do what they call a cannulation and run the blood. It's a big, scary machine. It's very alarming for parents in the NICU, and it is a tough machine to run. The nurses that do that position are very skilled, very knowledgeable humans, and I have the utmost respect for those ECMO nurses. But yeah, I was on one of the specialized towers, so we had pretty much the highest acuity in my tower. So right out the bat, I got all of the really sick babies, and it's overwhelming. It is scary, but I think the NICU is also a really great place for nurses who have a passion for not only kids but also women's health, because in the NICU you also have the moms there, so you're teaching them how to breastfeed. You're also going through all the postpartum with them. So it was a really good stepping stone, I felt like, between L&D and fertility, because it was a little bit of both, actually.
Yeah, yeah. One of the biggest problems that babies in the NICU, or premature babies, I guess I really should say, have is that they haven't yet really learned how to breathe on the
Mm-hmm.
outside. So, when your baby's on the inside, if we look with the ultrasound, past a certain point, we see actually breathing movement. And that's part of what's known as a biophysical profile. It's one of the tests that we can do with an ultrasound. And it's a sign of, it's a reassuring sign to see that breathing movement, but they're not actually breathing on the inside, but because the oxygen is coming through the umbilical cord, it's coming through the blood. So once they get on the outside, their lungs may not be mature enough yet to be able to deal with breathing the way we breathe as adults or as bigger people. And so always that's really kind of one of the challenges. People sometimes say, well, I want to have twins with my IVF. I want you to give me twins. And we have this conversation a lot.
You all give me
right?
anxiety.
Yeah.
Those of you that ask for that.
Because we say we really don't want you to have twins, because we want you to have one healthy baby at a time. And the reason for that is that with more than one baby, with twins or even higher, especially higher order multiples, you're pretty much assured there's a very high probability of a preterm delivery, of a stay in the NICU, and the potential for having lifelong problems. And so if we can avoid that with one healthy baby at a time, then that's what we do. What was the youngest baby that you ever took care of? Do you remember? Was it about 24 weeks, 23 weeks?
Actually, we had a 22-weeker in my pod. So I used to work for St. Louis Children's, and they initiated the small baby protocol right as I was kind of headed out. So there were specific nurses that were in charge of taking care of small babies. But prior to that, like I said, my pod was a very high acuity pod that I worked in. And so we got everything. And I believe the youngest I took care of was either a 22 or 23 weeker.
And that's a very little baby. So what we consider is that the point of viability, that is the ability of a baby to really potentially survive on the outside, is about 24 weeks. Now certainly if a baby is born a little bit earlier, we do everything that we can. And those are the kinds of things we call the micro preemies, because they're really very, very small and very, very challenged. And so 22 weeks is really early, and those 2 weeks can sometimes make really a very big difference, right? Yeah,
very much so. A lot of development happens really between, honestly, the 20 to 30 week mark. That's crucial for lung development, brain development, all of those things. So when you have those babies really early, a lot of times they come with a whole slew of specialties. Yes.
Issues. Lauren, looks like Lauren also says,
yes.
Yay, Macy, miss
NICU
my
girl.
NICU days. Awesome. Well, before we jump back into to questions here, it's about 1/2 the hour, and this is the time when every week I do what I call the 5:30 Fuzzies with Fink, and that is where we take a moment to think about all those people out there who are dealing with hard times, and that may be over this fertility roller coaster. That may be over getting a pregnancy and losing a pregnancy, or worrying about the pregnancy test that's coming up. That may be because of things at home, relationships. That may be because of school. That may be because of work. Any of those challenges in life can make us all feel very isolated and very alone. And so at this moment, I like us all to be able to stand together as one community and really send out the good vibes to everybody at this particular time who needs to know that they are not alone. No matter how isolated or alone you feel, we're here with you. In fact, I always say this particular group of folks who watch this broadcast would give the shirts off their back to other people who are in need, who are going through many of the same things that we've all gone through. So let us just break the internet with kindness right now and really send out all the good vibes from all of us to anyone out there tonight who needs it. You're not alone, and tomorrow is indeed a new day. And as I close the show with, it's a new day full of all new adventures. So that, my friends, is the Fuzzies with Fink. Let's send out those good vibes. Everybody who needs it, break the internet with kindness, if you don't mind. So thank you. Okay, so let's see. It looks like Deanna over here says, oh gosh, let's see. We conceived through IVF and had our beautiful daughter. When can we do another transfer? The other question is, I have endometriosis and my partner has male factor. He has since started anxiety medication. Will that make things worse? The last time he was on it was before IVF, and it was short term. Unsure if he'll be on it for long term. One more question. We transferred 2 embryos and 1 stuck. Should we transfer 2 again next time? So we got a couple of different questions here. The first one has to do with the anxiety medication and male factor. And I would say under most circumstances, that should not be an issue. So there's lots of different types of medication that we use, the most common of which is called the SSRIs, or the selective serotonin reuptake inhibitors. And those medicines are really pretty well studied and shouldn't really have any significant effect on sperm or on fertility. Even women who are on that medication, one of the most commonly prescribed classes of medication, I would much rather see you on that medication in pregnancy than be off of it and feel terrible. and be at risk. So I think it's much better really to be on it. As far as how many embryos to transfer, so we typically follow the guidelines of the American Society for Reproductive Medicine. And so that asks some questions like, what type of embryos do we have? Is it a tested embryo or an untested embryo? And how old are you? As well as how many transfers have you had before? So all these things kind of factor in. But if you transferred two previously, I would say there's probably little downside to you transferring to this time. Just kind of my gestalt of things there. So what do you tell folks when they say, "Well, gosh, when can I?" Well, so actually, let me just clarify there. Deanna, you said you've got, yeah, so you want to do another transfer.
Had your
So
daughter. Okay.
yeah, you had your daughter, and not sure how old she is now, but how long? What do you tell folks?
So the first thing I always say is if you're breastfeeding, we'd like you ideally to A, not be breastfeeding, and B, have your periods back. Or if you are breastfeeding, it's very minimal, even to the point of just like pumping for like overfill. But really ideally, we like to, especially Dr. Abishan, I know, likes to have those periods back and see those prolactin levels down. So that's one important factor of it all. And then if you're not breastfeeding, then typically I say OB clearance is your big one there. So I say have a chat with your OB about when they're the most comfortable, because a lot of times I don't know if you feel any different, but you guys go have these babies and then we don't know about the delivery really until you come back and tell us all of the nuances of
Or
those
what happened with the
deliveries.
pregnancy,
Yeah, or the
and
pregnancy
and all
after
the
10
troubles
weeks
that you had,
Yeah.
and so forth.
Yeah. So sometimes you guys just giving us that call of, hey, this is what happened. This is how things went. When can I jump back into it? That starts to, develop a new conversation of, oh, well, you had pre-E. Oh, you had this, you had that. So I would say breastfeeding, clearance with OB, and then just giving us a call to kind of determine what your next steps are.
From my perspective, as someone who used to deliver babies, I know that really the only preventable risk factor for severe preterm birth is a short interconceptual interval. So people who conceive very quickly after having a baby are at an increased risk for significant preterm delivery.
Mm-hmm.
So the American Academy of Pediatrics, and I think it comes from the American Academy of Pediatrics, says the ideal window is between 1 and 5 years for the next child. Now, normally I say, yep, breastfeeding, because we want that prolactin to be normal, and the medications and stuff that we use for transfer will affect the breast milk. So I don't want you to be breastfeeding anymore. 9 months is typically the earliest. Now, some people will have had a C-section and may have had some complication from that C-section, and that can sometimes stretch things out a little bit longer. But so like Macy says here, I think good conversation with the OB, but in general, 9 months would be kind of my ballpark where I'm kind of thinking. Let's see what else we have here. Perry Myslova says, a friend of mine is 6 weeks pregnant after a euploid FET, but has had some spotting on and off, and now it's more red than brown. She's really afraid it looks like the beginning of her period. Is there hope? And the answer is yes. So do you get involved in counseling those folks who are having that early pregnancy bleeding?
We do, especially when we have the call phone. We get a lot of calls after hours for early pregnancy bleeding. It comes down to, is she doing the vaginal suppositories? That's my first question. Every time someone calls with bleeding after an FET, have you been doing your vaginal suppositories? Those are known to cause cervical irritation, which can cause essentially bleeding. And that can range from just some spotting to, a good amount of blood, but usually not more than enough to need like a panty liner, really. And then our follow-up question to that is, have you had your first scan? Which it sounds like she's 6 weeks, so she should be around the
right
time
around that time, yeah.
First scan, and that's where we're looking for like those subchorionic hematomas, which can also cause some pretty concerning bleeding to you, but to us, we know that for the most part they are benign. Not always, but it's
Now, let's actually just talk about that for a second,
Yeah.
since I have you here. We talked a minute ago about that subchorionic hematoma and the alpha lipoic acid for that, but it's a pretty common cause of bleeding in the first trimester. And now that I have an extra pair of hands here, I'd like to show you what a subchorionic hematoma is. So go like that for me, if you would. So let's say that here, well, there we go. Oh, there we go. All right, that's better. Let's say that this is your uterus. Okay, so the baby is in here. Hi, mom. Right, baby's here. Baby's looking around. Right. All right. So slap me anytime. Right. So this is the cervix, and just by way of context, when it comes time to have the baby, the cervix has to do two things. The cervix has to start to thin out, and it has to start to dilate. Right. So it's closed right now. So it's a doorway leading to the uterus that's closed. But the placenta sits here. And all mom's blood flows through mom, through the umbilical cord, through the placenta and into the baby, and then kind of back around the system again here. Well, as the uterus grows, you see the placenta is going to move along with it. The placenta moves with the uterus. And as it does that, it can shear off a little space underneath here. And that's what we call a subchorionic hematoma, literally a little bruise that's under the placenta. Now, like any other bruise, if I were to punch you,
don't.
Dang it. All right. If I were to punch her, she would get a bruise, and it turns all kinds of colors. It turns yellow, it turns brown, and then kind of eventually turns blue first, I think, and then eventually it goes away because the blood that collects there just gets reabsorbed back in the system. But we're talking about something that's right down by the cervix here. So a lot of times, some of that blood just wants to more easily escape right out the door. And that's what a subchorionic hemorrhage is. Good job on the uterus there. I appreciate that. And it's a very common thing. 1 out of every 2 pregnancies has some bleeding in the first trimester. In our line of work with fertility, as Macy said, progesterone suppositories are a notorious culprit. But once you look and you see the heartbeat with the ultrasound, 95% of those pregnancies continue on without a problem. So that's what we're looking for there. We're looking to see that heartbeat.
Lots of hope.
Lots of hope. Oh gosh, look, MCRM Fertility has joined. Thank you for being here this evening. We've got Nadia, we've got Bienvenida, Bienvenida. Jake says, what's your position on 10 units of Lupron, 10 days before stims, and then Clomid for 5 days for someone with DOR, diminished ovarian reserve? So, kind of what you're talking about there is something that is called a microdose Lupron flare protocol. And basically, Lupron is medication that kind of tells the pituitary gland to either do its thing or to shut itself down. And when you're doing that short duration there, that's called a flare protocol. And what's a flare? You kind of shoot it up into the air. You're trying to get the pituitary gland to go and make a big burst of hormone. And that's what the purpose of the Lupron is. Clomid alone, sort of a microdose flare with Clomid alone would be an unusual protocol, especially for something like IVF, where we're trying to get as many eggs as we can, but sometimes I've seen that done just for ovulation induction. It's kind of an expensive way to do it, but yeah, it may just work. But there's some rationale behind that in terms of the physiology. So yeah, I get it for sure. Let's see here. Hi, Midgie and Angelina up in the wonderful state of Minnesota. It's always either Minnesota, in the state of Milwaukee. No, wait, in the state of Montana. It starts with an M. I know it starts with an M. Hi, Angelina. E. Winnick. Hi. Let's see. We've got Zaman. I always have a hard time pronouncing your name. Hi. Would PRP help to get more eggs? So ovarian PRP is something that is considered experimental. And basically, that's where you take some of your own growth factors from your body and separate them out in the blood and place them and basically inject them into the ovaries. So far, the data, the evidence on intra-ovarian PRP is mixed. It's not overly enthusiastic. But part of the reason for that is because I think we haven't yet identified the exact group of people for whom that will be helpful. Because now at MCRM, they have just stopped doing intra-ovarian PRP due to some reasons about the data not really being very strong. But we all have seen cases where it really seems to have done wonders for people. The problem is that it has risks. It's potentially dangerous. I know of 4 cases where people ended up actually losing their ovaries as a result of intra-ovarian PRP. Not fortunately at MCRM, but elsewhere. And so that's real. And when we don't know the exact group of people to treat, and we're trying to treat everybody with it, we may be exposing people to more risk than is necessary for an outcome that is really kind of unproven. A special shout out to Katie Zinzer here tonight on the Facebook side of things. Katie is a high fashion model, and why are you laughing at that? Why do you think that's funny?
I believe, yes, yeah. You're so right.
That's right. And if you don't believe it, I've got the pictures to show you, and I will. And I will. Katie, thank you for joining us tonight. We've got Adge, and let's see, Angelina said, my husband lived in Jacksonville. Oh, that's right. And I still have family in Springfield. Yes, I forgot lovely. About that. How about that? See, it is a small world. Hello, Aaron from Amazon. Nice to see you tonight. And Zeneda, good afternoon in sunny South Florida. Let's see. Liz is with us. Logan is here. And let's see what happened. There we go. Let's see. Marlena says, Plaquenil and prednisone is just for transfer, not retrieval, right? Well, so there are some protocols that use this thing. Why it's doing some strange stuff there. So you're shaking your head no.
Not for, well, the Plaquenil we don't use typically in egg retrieval, but prednisone sometimes.
Sometimes you'll use prednisone or dexamethasone in egg retrieval, but typically Plaquenil and prednisone are a combination that are used for people who have a positive ANA before egg retrieval. Yep. So you are exactly right there. Plaquenil, I wouldn't think would really do very much for I see what I did. I bet you I did that. I did. How do I don't even know how to undo it now. I accidentally gave us some kind of filter, but
whatever. I guess we needed it.
I guess it doesn't make me look more beautiful though. So I don't know what's happening here. And that's kind of the reason behind Plaquenil. Now, there is another medication that's called low dose naltrexone or LDN. Low dose naltrexone, I used to think of as something that was really predominantly better for embryo transfer rather than egg retrieval. But there's some pretty good evidence that it does help with egg quality as well. So I am using it more and more and feeling very comfortable with that for folks to help with egg quality. A Clark says, I started the ALA, that's the alpha lipoic acid, a couple of weeks ago, and the subchorionic hemorrhage has gone down to half of what it was. Yeah, that's excellent. How long do I take the ALA the whole pregnancy? No, I don't think so. I think that you are fine to really just take it until the hemorrhage is gone, which in most cases is going to be after about 12 weeks. In some cases, it can last through 16 weeks or so, but usually you see that as being gone. Angela Sack, good evening to you, my friend. Z asked, can the embryologist select X or Y before injecting them into the egg? It's a common question.
I wish.
I wish.
It would make my job a little bit easier.
Yeah,
sometimes.
it would be nice if we could select gender before we even make an embryo. But unfortunately, the way that works is that the embryos are made and then the gender of the embryo is identified. The selection portion has to do with deciding which embryo you're going to transfer. But yeah, wish you could do
Maybe
that.
one day. We'll see.
What do you think is the most common question you get? Well, let's say after hours. What's the most common question?
Like call phone?
Yeah, if you're managing on call and people end up with either a med question or a worry or something they're not sure of, what's the most common theme you hear there?
Honestly, most common is bleeding in early pregnancy. I would say really it's the patients in between that transfer to first OB timeline. I feel like that's when they're most alert of all of the changes in their body. So we'll get a lot of questions about any sort of spotting or cramping or anything associated with that. That is probably, at least it used to be, our number one call phone call. I would say IVF related, so more retrieval geared. It would probably be in relation to medication questions. One we get a lot is, I don't know if your clinic does this, but for the Menopur, we only use 1 ml to dilute instead of 2 mls because the medication burns. So we would much rather you do 1 ml of a burning medication than 2 mls of a burning medication. But people get so confused by the dilution of that. So we get calls about that a lot.
So what are your tricks and tidbits for tricks and tips for, one, how do you make Menopur not burn? So you change the dilution. Anything else?
Ice beforehand. We have been told by our patients, I don't know if this is actually true, you guys could speak to this, but by pushing slower, pushing the medication slowly, it's supposed to help prevent the burn as well. Those are really the 3 that I have. Do you guys have any others?
How about progesterone shots? How to mitigate the pain in the butt?
Warming up your PIO beforehand makes a big difference because that's a very thick oil that you are injecting into your muscle, and so it tends to dissolve and disperse much more happily for you.
So warming it up. Do you warm it up in your hands?
Yeah, we always say, actually funny, we always say in our hands, or Amanda loves to say between the breasts is a good way to warm it up.
Oh, really?
Yeah.
That's actually, that's a really neat trick. I'm not sure it works for me.
It wouldn't work for you.
Well, I mean, you haven't,
we don't know.
I'm wearing a good baggy shirt, so you wouldn't know, but that's actually a really good tidbit there. Yeah. Do you typically recommend folks use ice or heat after a PIO shot?
Ice before, heat after is my recommendation typically. So ice to numb the area. You can use a lidocaine spray or cream. I actually had a patient ask me about that today. It does go a little bit deeper than just those sub-Q injections. So, lidocaine injection would be probably more preferred, but that's not something that we readily have on hand or available to provide.
And not only that, lidocaine injections burn really
bad. It would
bad
be more,
themselves.
It would be more of a pain to do that.
But yeah, a spray on the skin, I think that's actually probably a pretty good solution there as well. And the other thing is, do you find that people have a harder time giving themselves the shot or when someone else gives them the shot?
I think it depends on the person. I feel like those that are scared of needles do better when someone else is doing it. But then I say that, and also sometimes they like being able to control it. So I think it's really patient to patient dependent. Some people prefer to have it done. Some people prefer to do it themselves.
Now, since we're talking about shots and we're talking with a nurse, let's just talk about that because, this can actually make a big difference in terms of how you feel. So with my recommendation with the sub-Q injections, I always recommend that you take a bit of it here, and this is a little higher
Pinch
than
an
it would be,
inch.
but you want to pinch, and you want to pinch the crap out of it,
Mhm.
because the more you're pinching it, then when that needle goes in, so you can place it in, and then you can kind of roll that between your fingers. That needle will go slide right in, and you
Mhm.
really won't even feel it.
Mhm.
So that's that. What do you say with a big IM injection, like a PIO?
Mhm.
Do you think it's better to just kind of go in, or is it better to kind of try to pinch that skin when you're doing an IM injection?
I mean, in nursing school, we're always taught to just kind of create a little almost bubble, I guess, with your hand. So if you're doing it with the L, you're just kind of pushing just enough to where that bubbles up, and then you're injecting. Because, I mean, as crazy as it sounds, when it's flat on, sometimes if you're going straight in, it'll kind of nick downwards, and no one really wants that. You want it more like a dart. So if you have that good bubble there, you have the right trajectory to go straight in.
The right trajectory. She uses big words. They teach them that in nursing school. And Katie says, pain in the what? Pain in the zinzer is what that was, is what
Yes,
I
a
just
pain in the
said there.
ginger. I
Pain in
like
the
that.
zinzer.
We're gonna
Um,
tagline that.
yes, indeed. Can you do a saline sonogram the same day as an egg retrieval, and then do a day 3 transfer in that same cycle? A fresh
Oh,
transfer?
not a fresh.
No. So at MCRM, for instance, pretty much almost everybody gets they call them a fluid ultrasound or a saline sonogram with their retrieval. And would you say that most people end up, or certainly many people do?
I would say, yeah, we don't really do them too often. They're not typically the recommendation. I would say, I don't know what our rate is on that.
It
My
seems
rate
like,
is like probably about 50 to 75.
all right, yeah, it just seems like a lot. So you can definitely do it at the time of an egg retrieval, but I would not do a fresh transfer
No.
after doing that, because really you want that endometrium to be untouched. You don't want anything to mess with it. You don't want it disturbed in any way. So
Mhm.
traditionally, if you're going to be having a fresh transfer, absolutely nothing goes inside the uterus. Now, sometimes, in fact, to do an egg retrieval, you have to go through the uterus in order to get to the ovary. And if that's the case too, the classic wisdom is don't do a fresh transfer.
Yeah.
Yeah. Would you recommend a PRP with an AMH of 0.12? Um, and, again, the PRP, the problem is we don't exactly know who the best person is for it. So an AMH tells us that you have a lower ovarian reserve, which means that there are going to be fewer eggs in the ovaries. Whereas I think the PRP, and the PRP is not going to make more eggs appear there. You're born with all the eggs
Right.
you'll ever have, right? So what it potentially can do is to try to improve the egg quality. So you may have a lower AMH, but with perfectly good, acceptable, normal egg quality, in which case PRP isn't really going to do anything for you. So I think, again, that goes back to, well, exactly who is it best for? Angela asks, oh, that's a good one. How about Lovenox, not to burn?
Oh, that is a good. So coming from L&D, we had a few patients postpartum on that, obviously, but then I went to the NICU. So I haven't dealt with Lovenox all that much. That would be a good question for my husband, who works on the cardiac unit. But I think it's kind of the same thing, icing the area beforehand, and like what Dr. Fink said, really squeezing that area.
Pinch
I
the
mean,
crap out
that's
of it.
literally what they teach us in nursing school. It's called pinch an inch. Like that
Oh,
is
is that what it's-
that is
oh, yeah.
literally
That's a thing.
the slogan.
Yeah.
So pinching an inch, and it's not just squeezing an inch, it's truly pinching. It also disperses some of, it's kind of like, pain points, trigger points. When you're pushing down on that skin, it kind of disperses the pain perception. And so then whenever you're doing the injection, but the burn is that's a whole different beast. Yeah, there's not much.
And really the reason it burns is because its pH,
Yeah.
which means its acidity is different than that of your skin. So when it goes in, those nerves are feeling it. I wish there was a better way around it, but
Yeah.
ice is the one thing. And again, really just pinch the crap out of it.
Yeah.
Do make that noise. That helps. It helps to make that noise. Folks, we're at the top of the hour now. Boy, time goes by so fast. But it is such a pleasure to be here with you every Tuesday evening, and a very special thanks to Nurse Macy for being with us. Macy from MCRM, and
Thanks
here
for
with me
having me.
live tonight in Tulsa, Oklahoma,
Yeah.
where it is a beautiful evening out tonight, and but I think the thunderstorms are coming later. Folks, like I always say, if you're dealing with this fertility thing, it is not the book of your life. It is just a chapter. And what are we doing? We are here to rewrite it together. Every step forward with love and kindness, and every step forward with hope, because tomorrow is a new day and it is full of all new adventures. So until next week, I'm Dr. Randy Fink. This is Fertility with Fink, and thanks for being here. Good night.
Bye, guys.